and especially the multifocals that we talked of, the angle kappa and things like that, that is the misalignment, and once you have the misalignment, the patient is really having a problem. So it is not uncommon. More often than not, there will be some mismatch between the centers. Okay? Thank you.
Maipal, you did mention about customization of according to the Q value. We may not have it from the same company, but we have options from different companies at different Q values. Is it your routine practice to measure the corneal Q value and choose the lens according to the asphericity?
No, not really, but maybe the ultimate question is as to what is the best for a patient. That exactly is not really known. So as more and more people work on it, because this is just the final scores going up into the quality of vision, but I don't. We could do that, and yes, if you have highly abraded or you have, like for example, post-refractive surgery, post-LASIK, etc., under those cases you would, but not as a normal routine. I don't do that. But yes, tomorrow I think we would be next couple of years as the quality of it, as you understand physics, because the optics were never understood in these details. It was just from an opaque glass you came on to an intraocular lens and it was curved. So basically I think things will evolve, but I am as a practice not doing it, but I think that's towards the goal of better quality.
I think to rephrase what Dr. Satyan was trying to ask, how frequently do you feel that these aspheric intraocular lenses are really resulting in a qualitative change as far as the patient's appreciation of this vision is concerned? It's all fine, optics is fine, we all understand that, we keep discussing about it. But are your patients who are getting an aspheric lens far more happier than your patients who are getting a conventional spherical lens?
Okay, if you ask me as a comparison, yes, the aspheric lenses, they were happier. They are happier, but if you ask me to say whether I'm going from a zero aspheric, that means the Boshelon category, to a Alcon to a Technis, I don't think there is any specific difference apart from one particular lens, I would say, which gives more amount of dystotopsia, which has got nothing to do with the spherical aberration. But apart from the quality of vision, I don't think there is any. Because how do you make a patient appreciate until, of course, you are running a study of one eye having one lens and the other eye having another lens, then only you can do it. So
Dr. Joe, would you like to comment on this? This is a question that's often discussed among the doctors. Because even though we keep talking about this concept of asphericity, customization and all that, how frequently our patients are happier just because we put in an aspheric intraocular lens?
For one thing, it's very critical to understand that this is all very pupil dependent, extremely pupil dependent. And so when you use a parameter of corneal spherical aberration at 6 millimeter zone, most of the IOL companies will say use the 6 millimeter number. But the Stiles-Crawford effect, as you expand the pupil, really drops around 4 or 5, really 5 drops. Unless you have a pupil that really gets out to 5 or more, you won't see some of these variable differences. So one of the things that's really important is to understand what is the size of your pupil under night conditions. What is the scotopic pupil of the patient? Even if they have a corneal positive asphericity, but their scotopic pupil is only 3 millimeters, then you won't see any effect from any of these lenses. That's just basic physics. So please look at the pupil size of the patient to really make a determination of if you're going to have a scotopic pupil where there is this potential for effect. But certainly the centration issue, if I can comment about the design of the ABC lens, centration issue is really an additive issue that can be better managed by a lens that is more forgiving, which the ABC does.
No, actually, you still haven't answered the question, which I was also not able to say. What is the clinical impact of putting an aspheric lens? Does it really matter to the patient, or irrespective of the pupil? There will be some who will have larger pupils, some who will have.
Well, like I said, if the pupil is a large pupil, yes, you can get a variation and improvement in contrast performance under scotopic conditions. It's very nominal, I'll just tell you that. I think the differences they're talking about are very nominal. And second thing, which we were trying to do at Tracy, and we were asked by some of our users, having just...
And then, if you have time, we'll take more questions. Now I have Dr. Suhas Nandipurkar, who needs no introduction anywhere in India, to come and talk to us about toric intraocular lenses, what's new. Arun, while he's hooking up, maybe you can ask your question.
Yeah, because the talk didn't answer the question about how the tilt is being utilized in this lens. Because tilt, as well as a little bit of decentration, may induce a little bit of coma, as well as astigmatism. How this lens utilizes that. And one more point, so many studies done by Holiday, he says if pupil goes beyond 5.5, as you said, style proper effect utilizes all other aberrations. So measuring beyond 5.5 is really doesn't add to the quality of vision. So even after cataract surgery, capsulorex is made 0.25 or 0.5 overlap over the optic of the IOL. Basically, practically leaves around 5 millimeter of effective optical zone. In the most, maybe if you will are 6 millimeter. So measuring beyond 5.5 is really not effective. And most of the IOLs, as presently available, they have a negative spherical aberration maximum at 6 millimeter. In central part, they are not effective. And as we all know, in center 2, 3 millimeter, all these aberrations has minimal effect. So how this affects the quality of vision and how the effect of tilt is utilized by this lens?
That's a very long question. We'll take it up in the end.
We will answer it next week. If we want to answer.
I thought actually of presenting something, but I ended up realizing it's a question. So let's finish with Dr. Suhas's presentation. Toric IOLs.
Yeah, just a little bit to the discussion that was going on. There's a doctor in Bombay, Dr. Shah.
And he has got his clinic, which he has named as 6x4 clinic. And he has his own design of a lens, where he takes into account it's literally customization of each lens. And he says, by looking at the asphericity and the Q value, he is able to consistently give 6/4 vision. So when we talk of whether the asphericity really matters, it would not be in our general life, but when it comes to checking his visual acuity or his final quality of vision, probably, or a normal, more than normal depth of vision, probably that must be, matching. Anyway, let's come to toric. Nowadays we talk a lot about toric lenses. Suddenly that astigmatism has become untouchable. Imagine, ever since we did cataract surgery, the astigmatism existed. In fact, when we did a regular conventional type of cataract surgery, it was so huge. And with every newer developments in cataract surgery, the induced astigmatism went on coming down. And today, in fact, we rarely cause a lot of addition into the astigmatism, but still we are very sensitive to it. And there's a very reason why. The astigmatism, of course, its prevalence is much higher today. I mean, it's pretty high in the elderly population, sometimes going up to more than 1.5 in almost 50 to 20%. But there's a higher demand consistently for uncorrected good vision, and rightly so, because new IOLs and all the premium IOLs depend on post-op emmetropia, like multifocals, aspheric lenses and accommodating lenses. And that's the reason there's an acute need to ensure that you don't cause any additional astigmatism, or if there is some, you correct it. If you look historically, 92 92 was the year when a PMMA with toric component was introduced. In the year 94, we had the first foldable, although there has been a lot of changes that have occurred since then, and they continue to occur. In fact, today we talk of now, to a large extent, the lens has been corrected, but what remains is whether we are accurately determining the axis and accurately placing the lens in the desired axis. So if you look at some of the pearls of toric practice, obviously no contact lens for 2 weeks before the measurement, and measurements form the most important component of toric practice. Refraction, obviously, then comes the cornel measurement, and cornel measurement, in routine practice, for most of us, it is not one machine alone that gives you. If you look at, this is the ITracy picture, where it shows you a symmetric astigmatism, then you have this asymmetric astigmatism. Talking about these topography, Placido disc video keratoscopy, it has its own limitations. Changes on the posterior corneal surface, like in early keratoconus, are missed. Peripheral pathologies such as pellucid marginal degeneration is missed, as Placido disc only gathers data from central 8 to 9 millimeter, and obviously it doesn't account for posterior astigmatism. And in this market where there are many lenses that are already available, we have something new, and that's ICERT 351 toric from Hoya. And the best part of it is it's the first MICS preloaded lens, and it makes a huge difference. You have that no touch, a lens that goes through 2.2 beautifully. It has obviously square edge and new polishing process. Some of you who have been lucky enough to have visited the factory, you know the difference in the way this lens is manufactured, the way it is polished. It's amazing. Sometimes I feel the surface that Hoya lens has is one of the best surfaces on an AIOC. They spend a lot of time in doing that pad polishing, because its haptics are unique in a sense. It has got the enhanced visibility of haptic tip, and it avoids sticking of the haptic tips on the optic surface. And the best part is, once you insert, it's a one-step insertion where both the haptics go into the bag, and it prevents or avoids one extra step of putting it. It's obviously yellow tinted, aspheric, and we have spoken about the ADC design. If you look at the technical details, this lens is obviously a hydrophobic material. It's a single piece, and it's available from T3 to T9. Talking about optical design, the anterior surface is aspheric design, and the posterior surface has cylindrical power. Anterior surface has aspheric, which is ADC, and the posterior surface is spherical, which has cylindrical power. This is a picture which shows the pad polishing that is done on these lenses to give the excellent surface. It's available, like I said, from 1.5 to 6, where the available cylindrical power is 1 to 4 diopters. The lens marks on this are little more prominent and little more bigger in size as compared to the other lens, so visibility is better. We have this Hoya toric, which is an online toric calculator, which gives you an option of 3 different options, like you can have a slightly more cylinder, or a little less, or little the minimum. You can choose between the 3. And the best part of this toric calculator is you have this examination view, or you can have a 12 o'clock view if you are going to sit at 12 o'clock, or the temporal view. And finally, you get this picture where most of the details like other calculators are given. When it comes to the important part of reference marking technique, you have the freehand technique or the others. In the freehand technique, you can use a marker pen, you can use a bubble marker, you can use a gravity marker, or any of these. In the freehand, you use the nimbus is marked at 6 o'clock with either sterile ink pen or spatula. This is how you can use, and there are various different markers, and it forms the most important part of toric practice, where your marking has to be most accurate. This is my choice. I prefer the pendulum type, which is gravity based, but it's a choice. This is the bubble marker. It's a little difficult to use, but it's also one of the accurate ways of doing it. We can also use Akahoshi. I have used it, but I'm not very comfortable. So I settled for the gravity one. When it comes to marking it, one has to remember that placement errors can happen due to error in marking the reference axis, and you can have translational errors. It involves two issues. Either in making sure that 0 to 180 meridian is true horizontal, and making sure that the marks bisect the cornea through the optical center. This picture shows you might mark two horizontal marks accurately, but they are not crossing or bisecting the center. So you have to make those final adjustments when you use your Mendes marker on the table. If you're using split line for marking it, patient should be looking at the light with the other eye closed and move the slit lamp across the cornea until you get a bright Purkinje image, and that's when you get the perfect marking. You can also use it.
Dr. Swas,
Yeah.
I am under pressure from the glaucoma people.
Oh.
The session time.
Yeah. And you should also remember that there is a cyclocaution that has to be taken into consideration. This is how you mark it. I'll take 1 or 2 minutes. It's okay. Yeah. This is the preloaded lens, and once you inject it, in one step you have both the haptics going in. Rotational stability, talking about it, the AIOC material and design after implantation of toric lens in the capsular bag, the anterior and posterior capsules fused with AIOC which prevents AIOC rotation, and the AIOC material and design contribute to its rotational stability. AIOC material, the properties contributing to its rotational stability are adhesion of posterior capsule by extracellular matrix proteins, the tachiness and central thickness, among which the hydrophobic is the most, the best lens. If you talk of the extracellular matrix, the proteins involved in AIOC adhesions, they could be fibronectins, vitronectins, and collagen type 4. These proteins are present in plasma but also available in the aqueous humor after cataract surgery to breakdown of blood aqueous. In hydrophobic lenses, the fibronectin binds hydrophobic acrylic lenses, whereas collagen 4 binds hydrophilic acrylic lenses and vitronectin binds the silicone lenses. Then hydrophobic material is tacky, it will not move easily in the bag once implanted. And this is that ISERT lens. And then of course we have the eye tracing, in which we have this workstation that gives you how you can choose which particular type of corneal measurements you would like to use if you want to measure the corneal with the toricity. The data entry screen opens and the user can choose to use measured wavefront derived astigmatism or the measurements from SIGK or the one that he wants to choose. And we also have, if you break down the toric panel, it will show you the details, but I will rush through that. And finally, a truly powerful feature for improving toric precision is the Zaldivar caliper. The pre-surgical ink marks are inherently inaccurate. But what if you had a tool that eliminated disconcerting by measuring from this or another landmark to the axis of placement? And that exactly is what achieved with this Zaldivar caliper, where you can use some of the landmarks like some of the vessels or a scleral range, and you can accurately identify how many degrees from a particular marker one should go away to make your desired marking. And the best part of this is that the toric enhancement program. If you have placed a lens and you don't have the desired result, you could always place keep the patient on eye trace machine even with the pupil undilated, and the machine will tell you exactly how many degrees away from the desired axis your lens is, and then you can take the patient back into the theater and re-rotate the lens to the desired axis. So in conclusion, toric lens technology has come to stay and will be a standard part of our daily counseling and continue to improve in its results. Thank you.
Thank you, Dr.
Before I go on, thank you Tanuj and thank you AIOS for this opportunity. There are no financial disclosures. Well, the outline of this talk would be gonioscopy, which is an invaluable part of diagnostic tools available. We'd go through a brief outline about techniques and what to look for, a couple of clinical scenarios, and maybe validate the clinical impressions with the UVM if we have time at the end. So, visualization of the angle in vivo was not described until Trantas in 1907 indented the limbus of a keratoglobus eye, bringing the angle structures directly into view. Now, this distortion of the globe is obviously uncomfortable for the patient and provides only a limited clarity. Trantas in 1918 coined the term gonioscopy from the Greek gonia, which means angle, and skopin, which means seen, to refer to the examination. Why is it important? It's because direct observation is not possible with observation of the angle is not possible. The scleral tissue projects anterior to the angle and the curvature of the cornea creates an internal reflection. What the gonio lens does, in effect, is permits visualization of the angle by eliminating the cornea as a refracting surface by placing a concave surface against the cornea. So the types that we all know of are the direct and indirect. It only means that the light rays are refracted directly to a cornea contact lens interface. You require a handheld slit lamp preferably, but you can also do it with the tilt of a microscope in the OT for magnification and illumination, and the Queppe lens is the prototype. But what is clinically used day in and day out is indirect gonioscopy, which uses the principle of total internal reflection, and the light rays are reflected by a mirror in the gonio prism to the observer and focused with a slit lamp biomicroscope. But because it's a mirror, the angles that are seen are opposite to what you're viewing. So the most commonly used, we'll be talking of indirect gonioscopy, the most commonly used ones are the Goldman 3 mirror and the Zeiss 4 mirror. You get an direct virtual image of the fundus as well as an indirect view of the angle. But a Zeiss 4 mirror for glaucoma or any 4 mirror for a glaucoma practice is more useful. One, you get a view of all 4 angles at the same time. Secondly, the curvature is less than that of the cornea, so you can indent it and look out for whether the occlusion is synechial or not. So which gonio lens to use? There's not much to choose as long as you use one. The advantage of a 3 mirror is that it will be good for a multi-speciality practice where you can see peripheral retina through some mirrors. The disadvantage is you'd have to rotate it to look at all 4 angles. But if you're doing primarily glaucoma practice, then as I said, the Zeiss 4 mirror type is very, very useful because the diameter permits indentation gonioscopy. So just a quick word about the slit lamp preparation, the lens preparation and the patient preparation. So you need low magnification and low illumination to start with. A parallelepiped is useful, 2 millimeter width and maximum height. To see the angle in its entirety, it's nice to orient the beam parallel to the axis of the mirror, vertical for the superior, inferior and horizontal for nasal and temporal. But be careful not to impinge the beam of light on the pupil and prevent artifactual angle opening due to pupillary constriction. Between patients, hydrogen peroxide ideally, and it should be allowed to air dry. So a practical thing what we use is have it in a petri dish just next to our slit lamps, and it's dipped in that and air dried before putting in. So between patients, that's a useful, quick way of cleaning it. But at the end of the day, it's always cleaned with soap and water and rinsed with saline and allowed to dry. Do not use absolute alcohol since it's been found to damage the lens. Usually, the Goldman requires installation of some fluid, 2% HPMC does just fine. You need to fill the concave surface if it's a Goldman, but the indentation ones don't really require it. The tear film is good enough, and there's no coupling fluid necessary. So it's important to explain to the patient in layman's terms. I've put an acclination tonometry picture here because the way the patient is seated on the slit lamp is pretty much the same. The forehead against the forehead rest and align the lateral canthus with the alignment of the slit lamp. So you need to instill the anesthetic and always try to do the tonometry first, because if you've done a gonioscopy and you've already pressed upon the eye inadvertently, you might have fallacious rise or even lowering of pressure at times. This little girl is just 3 years old, and just to say that if you're really friends with your patient, anybody will let you gonioscope. She's an exception, of course, but it is possible. So when a resident comes and says, gonioscopy not possible in this patient, I'm not really impressed with that. Because if you talk to them and you are gentle with your technique, most patients would cooperate. So you need to grasp the gonio lens with a thumb and forefinger. Have the patient look down, firmly grasp the upper lid with a thumb. Rest the gonio lens on the lower lid margin. Tilt the lens up to meet the cornea by asking the patient to look straight ahead to meet the gonio lens. And then gently place the gonio lens on the cornea. It's important not to press upon it, because then you might artifactually open an occluded angle, which might be occluded not by synechia. Common problems are an air bubble when the lens is not flat on the patient's cornea. So what you need to do is try tilting the gonioscope towards the bubble and push lightly on the eye to try and squish the bubble out. Sometimes it works, and sometimes in spite of a small air bubble, you might still obtain a good enough view of the angle. So you don't need to manipulate it too much more. But with excessive pressure, you would inadvertently press upon the cornea and open up an appositionally closed angle. So you need to be very careful about that. So now that we've got the procedure in place, what do we see through the gonio lens? Obviously the angle structures, and what is seen is from anterior to posterior, the Schwab's line, and then the trabecular meshwork, and then the scleral spur, and then the ciliary body band. So these are the 4 structures that are here, and this is a nice open angle which you would call normal. So the Schwab's line is really, I put this up, it's from an Axenfeld, but this is what it looks like. It's termination of Descemet's membrane where the corneoscleral meshwork terminates anteriorly and looks like a thin glistening white line, more commonly in the interpalpebral fissure. So what you look for on the Schwab's line is you can have pigment which can accumulate at the ledge, something like this. It's wavy, and that's called a Sampaoli's line. You need to look out for that more in the superior angle, which is the inferior mirror, and then it is seen in pigment dispersion, exfoliation, but also remember uveitis, trauma, any sort of intraocular surgeries can have excessive pigment release as well. But if a trabecular meshwork, which should be normal and grey like this, it's many times brown in brown iridids also. But if you have significant pigment as though it's painted across the trabecular meshwork like that, that's unusual. And then think of exfoliation or pigment dispersion or previous inflammation. This is really pigmented trabecular meshwork which you should not lose sight of. The Schlemm's canal is not usually seen unless there is blood in it. This is somebody with Sturge-Weber syndrome where the blood had refluxed into it. The pigmented band corresponds to the canal of Schlemm posteriorly. But if the pressure within the canal is lower than the pressure in the anterior chamber, usually there won't be blood in it. But if you see blood in the lens, then it's important to look for why it is there. The scleral spur represents a continuation of the sclera into the anterior chamber. It's attached anteriorly to the trabecular meshwork and posteriorly to the sclera, and it appears like a thin whitish band just behind the trabecular meshwork. And if you see the scleral spur, you're pretty much sure that the angles are open. Usually the ciliary body band may not be seen, but in light eyes or aphakics or pseudophakics, it's much easier to see them. And it's usually brown or charcoal grey in the dark eyes that we see, and it's broader inferiorly than temporally. If you see an abnormally whitened ciliary body band, of course, ask for a setting of trauma and always compare with the so-called normal eye. Why is grading the angle so important? Because angle closure glaucoma has a renewed interest as a major cause of blindness in India. And what grading to use? It doesn't matter. Any, as long as your definition is consistent. What is important is for you to recognize occludability, whether the angle is occludable or not. And we did this study in which we assumed that the UBM would be more useful in grading the angle compared to gonioscopy, and we found that it was much the same. There was not much to choose between the two where grading the angle was concerned. The UBM is useful to find out why the angle is occluded or closed and what's happening behind the ciliary body band, but you don't need a UBM to tell you whether the angle is open or closed. So this is the definition of the occludable angle, which is widely used today, where the posterior part of the trabecular meshwork is visible in less than 90 degrees of the angle. Now that's considered occludability. What else to look for in a gonioscopy? Iris processes. They insert from iris to the posterior trabecular meshwork. They are normal in occurrence, but they're supposed to be mesodermal remnants. But if they are very numerous, think of mesodermal dysgenesis or one of those anterior segment dysgenesis syndromes, especially in young patients. Peripheral anterior synechiae need to be differentiated from iris processes because these are thick portions of the iris which are attached to either the angle or the anterior shore base, and they're characteristic of previous uveitis, inflammation, trauma, any insult to the eye. That is what causes the iris to stick to it. And the difference is that you can't see the trabecular meshwork between them as you could see in iris processes. And on indentation, the synechiae will continue to hold against the angle wall, but processes become lacier and you can see the wall behind them. So this is abnormal and it interferes with aqueous outflow, but iris processes per se don't interfere with aqueous outflow. So just a word about manipulative gonioscopy. Sometimes you see very convex iris where the angles are open but the entry is very narrow. So then you need to look over the hill, or you may unnecessarily label them as angle closure. Like in this eye, if you see this here, so you can't see it when the patient is looking straight, but what I told the patient to do is look towards the mirror and just tilt it towards the angle and you can see the posterior pigmental meshwork very well. So it's narrow entry, yes, but the angles haven't closed as yet. So this is the manipulation that we use. We ask the patient to look in and then the eye rolls away from the angle being viewed, and it's easier for you to look over the hill of the iris and see the angle. But apart from that, if even by manipulation you think that it's not working and the angle still appears closed, the principle of indentation gonioscopy can be used. Now the principle is that if you press upon the cornea here, the aqueous will go into an angle which was occluded, but the pressure of the aqueous can cause the angle to open up because the iris is pushed back, which means that you do need to reverse the pupillary block before these become synechial and become permanent. So when do you do that? When after manipulation also the angles look closed, and it is to differentiate synechial appositional closure, and it's also useful to demonstrate the double hump sign in the plateau iris, which I just showed you. So this is indentation, so this was the angle which seemed closed even after that, and you see these Descemet's folds which have happened after the indentation and the angle has opened up. So it is closed, yes, it is occludable, but it's not synechial closure as yet, and this patient with an iridotomy will do just fine. Now if you have a flat looking iris like this, and it takes a sharp turn posteriorly before attaching to the ciliary body, it's a condition called the plateau iris, and there indentation works very well because you can see the double hump sign there, where the iris is draping over the root of the ciliary body and causing the angle to close right in the periphery. So many times if you do an iridotomy, because there is a pupillary block component to it, it might work, but if it doesn't, you might need to resort to an iridoplasty later. But it's important to recognize these conditions of plateauitis, especially in those angles in which the pressure doesn't go down even after a patent iridotomy. So this is just to demonstrate that how a patent iridotomy might not work simply because the ciliary process is there. And this is after an iridoplasty where coagulated burns on the peripheral iris has pulled it away from the angle and caused the angle to open up. So then it's important to record gonioscopy findings. The features recorded, this is what is usually done in our clinic. It's a cross. And you label the features that you can see. So what this means is scleral spur. And you see pigmentation in the trabecular meshwork is graded 0 to 4. It's very, very subjective, yes, but it's some indication that you've looked for them and whether the configuration of the iris is convex or not. So here one quadrant is flat, but the rest are convex, and you can see the scleral spur in all quadrants. So we've talked about how we clean and disinfect them between patients with isopropyl alcohol or H2O2. End of the day, we disinfect them again and soak for 5 minutes and rinse thoroughly with saline. So gonioscopy is really an essential part of a comprehensive eye evaluation. There's no glaucoma evaluation can be complete without it. It's invaluable in diagnosing many puzzling situations and is well worth the extra little time and effort required. Thank you.
Thank you, Dr. Sushmita. I think she has very nicely covered the basics of gonioscopy, and there is a slight change of schedule.
Important. I think as ophthalmologists we all treat glaucomas, but sometimes we actually mistreat them because we don't know what is causing the rise in IOP. And again, she had mentioned that angle closure is a very important disease as far as we are concerned. Most of the hospital statistics have shown, whether in North India or South India, that 50% of the glaucomas that we see in India are actually angle closure glaucomas. Most of the time it's primary angle closure, and if you consider that if you had done a gonioscopy when the patient was first seen, you would know it's an angle closure, you would do an iridotomy and prevent any further angle closure from occurring. So giving medication to control the IOP is not what you need to do in an angle closure eye. What you need to do is to first diagnose the glaucoma and then be able to quickly do an iridotomy so that the angle closure doesn't continue, and whatever you need to do in terms of controlling the intraocular pressure to target IOP therefore becomes much more meaningful. I'll just step back a little bit, and if you look at the diagram shown over here, basically what we're trying to say is that the first time you do a gonioscopy, you're not really sure what you're looking for. So people who are planning to learn how to do gonioscopies, as Sushmita had said, please try and do it on aphakic eyes or even pseudophakic eyes because they tend to have a deep AC. And what you have to know is the anatomy. So if you look over here, you can see that this is where the Descemet's membrane actually ends. This is what we call the Schwalbe's line. And the trabecular meshwork is actually much more anterior than what we think from the ciliary body. So if you look on gonioscopy, you're going to be looking for the Schwalbe's line. You're going to be looking for the anterior trabecular meshwork, the posterior trabecular meshwork, the scleral spur. Then you're going to be able to identify the ciliary body in an angle which is wide open. On the other hand, if the angle is more narrow like this, you're probably only going to be able to see the Schwalbe's line and maybe some part of the anterior trabecular meshwork. Alright? So just to get to reiterate, basically what we need to identify is a landmark. And the most important landmark, and something that you can see in every single patient that you want to do a gonioscopy, is the Schwalbe's line. So again, this is what we are looking for, and you can see that this is where the cornea ends, and this can be identified very easily by using a very thin slit, a very bright slit, and then you can see where the corneal wedge actually is. So at this point where the anterior and the posterior surfaces of the cornea no longer become visible, that means the two anterior and the posterior surface fuse, this is the Schwalbe's line. And if you do this before you do anything else, you'll find that identification of the Schwalbe's line helps you to identify what else there is. So that is our anterior margin. The second thing we want to identify is where is the iris. So if you look at that, these two, you can see for yourself what a distance there is between the Schwalbe's line and the iris, so you're reasonably certain that the angle is wide open. Again, this is an anterior segment OCT picture. This is again to remind you that what you're seeing as the corneal wedge is this clear area. This is what is seen clinically, alright? And this is the other thing that you're likely to see. So you have an anterior margin of the angle and a posterior margin of the angle. And if you look at it end on, again you can see that this is where the corneal wedge is formed. This is your Schwalbe's line, this is the iris. And you can see that they're much closer than in this picture where they were quite a distance away. Okay? So if we keep that in mind, alright, what we are aiming to do is try and see what is the distance or what is the angle formed between the most peripheral cornea and the most peripheral part of the iris. Alright, so we start here. We have a light beam, and you can see that the light beam has two edges. So you choose for yourself whichever is sharper, and you look at that. Look at the edge on the peripheral cornea, and you look at the edge on the iris. And the angle that it appears to form over here is almost 40 degrees. Okay? You're then going to try and see what Shushmita had said as a white line, and you can see the white line very clearly here as the Schwalbe's line. And you can see the iris is down here. So there is a wide area of the trabecular meshwork visible between. Now when we come to this patient, you can see that we are following one edge of the light again. You follow this edge and it seems to go here, but it's not actually in continuity over here. So there is a parallax. That means it tells you that the light is actually falling behind, and you're not able to see the light as it goes behind this iris. So it looks as if the angle over here is probably about 25 degrees. Does that make sense? Is that easy to follow? Especially the residents, I can see some young faces over here. Does that make sense to you? Yes? Follow one edge of the light beam. Okay? Here on the other hand, you can again see that this is a light beam going over here, but the iris seems to be almost in contact with that light beam. Alright? And you can see that the angle is extremely narrow, possibly about 10 degrees. So just again to reiterate, what we are measuring is the angle between the most peripheral cornea and the most peripheral part of the iris, which is this. This is the angle that we are trying to measure, and this is called the angle reset. To judge a patient as having an occludable angle, what you have to see is that the posterior trabecular meshwork is not visible over at least 180 or 270 degrees of the angle. It's something that is highly debatable, because if it's not visible in one quadrant, why would it be visible in the rest? But these are the definitions that have been given. Alright? And the other thing is that most angles which are less than 20 degrees are those that are most likely to close. This black arrow in all these slides is just continuing to show you the Schwalbe's line. So if you keep looking at it, and with a little imagination, you can see that there's a white line here with a little bit of pigment anteriorly. Similarly, again, you can see this is a white line here with a pigment anteriorly. So you can see the anterior trabecular meshwork, but you're not seeing the posterior trabecular meshwork. Similarly, here you can just about see the anterior trabecular meshwork, but nothing else is visible. This has already been described. These are two ways in which you can actually see over the convexity of the iris to the area of the trabecular meshwork. And though this is supposed to be video gonioscopy, I've always found it difficult to explain to people on a video gonioscopy. So I've just broken it up into photographs. So we have this one patient in whom there's a light beam that is shone, and if you notice, the light beam is very short. So the light beam should actually be only 2 millimeters in height. Alright? Just about reaching the iris and reaching the peripheral cornea. So what you can see over here again with a little bit of imagination is a white line over here. And you can't see too much of the trabecular meshwork, definitely not the cerebral spur, definitely not the ciliary body. So what you then do is you narrow the slit. And on narrowing the slit, you can see that the anterior and posterior surfaces of the cornea are meeting over here. Again, the white line. And as you narrow the slit, you can see that the angle will become even narrower. Look at this angle and look at this angle. This is exactly the same eye. The next couple of minutes, you can see the angle narrowing because the light is not reaching the pupil. The light has become smaller. So you're identifying the Schwalbe's line and you're looking at the angle form. It's about 10 to 15 degrees. If you now widen the slit, or if you allow it to touch the pupil, you can see that I've now lengthened this. This slit was short, 2 millimeters. I've now lengthened the slit. Immediately this convexity of the iris tends to become flat. Is that visible? Yes? So immediately it becomes flat and you can start beginning to see the trabecular meshwork. But when you are identifying angle closure, this is not what we want. This is the end of your examination. What we want is this, a very thin slit, 2 millimeters in height, helping you to identify the Schwalbe's line, helping you to identify how far the iris is from Schwalbe's line. Okay? It also then tells you what is the angulation at the back. Okay? So this is showing you what happens when the light reaches the pupil, immediately flattens out, you can see more of the angle. So if you had started like this, you would have said this patient has an open angle, just give prostaglandin, just give timolol. On the other hand, when you do this, you know that there is a possibility of closure, or he's possibly had closure, and desperately needs an iridotomy to do a good management. Okay? And here, ultimately, when you widen the light out, you can see that there are a number of blotchy pigments that are seen in this particular eye. Again, there are angles and there are false angles. Alright, so just to highlight the fact that you can see, again, this is one patient. Here is the black arrow showing you where the Schwalbe's line is, and the iris seems to be very close. When we widen the slit, you can see that the angle opens up almost completely. Here is your white line, the Schwalbe's line, and the angle is widely open. So this is an occludable angle, but there's no evidence of closure as of now. On the other hand, you see an angle like this, and you can see that there's a brown pigmentation in front. I can tell you half my residents would probably say this is the trabecular meshwork and the angle is wide open. But actually what highlights the fact is that there is no parallax between the light beam as it comes here and as it goes over the iris. And however much I try to open it up, you can find that the angle doesn't open. So this is a completely closed angle, and the pigment dispersal anterior to the Schwalbe's line makes it look as if the pigmentation is a trabecular meshwork. Alright, so just going through a few things that we expect to see once we've decided that the angle is occludable, we now want to know has at any time angle closure occurred? Because 1/3 of us as Indians walk around with an angle of less than 20 degrees. But only 1% of us thankfully develop angle closure glaucoma. Alright, so the 29% you're going to actually distinguish by saying, is there evidence of closure? As you can see, here's Schwalbe's line. I keep telling you, the black arrow is the Schwalbe's line. So here's Schwalbe's line, and you can see the iris being tented up. Can you see that? There's a little hill that you can see over there. It's being tented up and it's stuck over here. So we have what is called a synechia over here. On the other hand, if you look here, you can see these little filiform synechia. They're little fingers. This was a lady whose mother had angle closure glaucoma, and she said, I brought my mother in, and we said, why don't we check your eye out? And this is what we found in her eyes. So these are filiform synechia that are the first evidences of angle closure. On the other hand, you can sometimes just see these blotchy pigments. Can you see this? These blotchy pigments are not the pigmentation that we, as Indians, we are a pigmented race. So as Indians, all of us over the age of 40 are likely to show you some amount of pigmentation, but it's a diffuse pigmentation in the inferior angle. So if you see something like this in the superior angle, especially if it's blotchy, can you just see this? One here, one here, one here. This tells us that at some point the iris was in contact with the central cornea, part of the stroma has been left behind, and then the iris has fallen back. Okay? Here are other evidences of synechia. But if we were looking at the previous one, you can see that the Schwalbe's line was visible, and these synechia are all below the Schwalbe's line. So these are what we would call goniosynechia or iridotrabecular synechia, as compared to this, where you can see that it is going all the way up to Schwalbe's line. Alright? So this is what we would call iridocorneal synechia. Alright? These are commonly seen with acute angle closure or sometimes with uveitis. Okay? Gonioscopic recording you can do any way you like, as long as you write the parameters that are important. I think Shushmita has already said this. What we insist our residents also do is to try and determine what they think is the angle in between the most peripheral cornea and the most peripheral part of the trabecular meshwork, and we make them record it on a diagram like this, so we know in 360 degrees how much of the angle is open and how much is closed. It's something we try very hard to do. It's not always possible. Again, just to end, please see that there are more things than relative pupillary blocks. So we've got this patient who looks as if, this is a small, as you can see, a 2 millimeter angle. And you can see that the Schwalbe's line is there and the iris is here. It seems to be quite open. When you actually do an indentation, again you can see, as she has shown you already, a double hump pattern. So this double hump is caused by the edge of the lens and the ciliary process pushing the iris up. Don't forget that there are many reasons for secondary angle closure, the commonest of course being neovascular glaucoma. You can see the ectropion uvea, and if you look carefully, you can actually see some neovascularization in the angle. You can sometimes have iridocysis like this, which can occur idiopathically, and sometimes it can occur as part of angle closure disease itself. Here you can see the NVI very clearly. You can see the neovascularization coming from the iris and going all the way up to Schwalbe's line. Or you can get other reasons for angle closure, like this melanoma. You can also have anterior chamber IOLs pushing the iris onto the trabecular meshwork and then producing enough inflammation to cause synechiae. You can see also that there's an extensive amount of pigment that is visible. So I'd just like to say that gonioscopy is indispensable if you're going to be treating glaucoma. Just keep 2 or 3 things in mind when you do it. You must know what you're looking for. You must have an anterior border, you must have a posterior border, and 2 very easy things to identify are Schwalbe's line and the iris that you can see. Between these 2 is your trabecular meshwork or whatever is visible of the angle, and therefore you then have to determine what is the angle between these 2 structures and what is the visibility, so that you can actually say, out of the 30,000 or whatever, 30 million people that are roaming around with narrow angles in this country, only 1 billion are probably going to need an iridotomy, and you identify them properly. Thank you very much.
Thank you so much, ma'am, for making it simple. Ma'am has to leave now, so if there are any particular queries on this topic, please